Hi everyone, welcome back to the 11th session of the CBT class. We've already covered almost 2/3 of all the topics that's covered in this class. So hopefully by now you're becoming a CBT expert. Today we'll focus on treating anxiety using CBT skills and techniques. Many of the same skills and techniques that you've learned in class can be directly applied to anxiety treatment in CBT. There are some specific cognitions that are targeted in anxiety treatment, which also has a direct implication on how you conceptualize your client's case. So I will begin the session by briefly reviewing kind of general information about anxiety disorder, and then I will move on to talk about this specific cognitions that are important to address in anxiety treatment, and then also discuss some of the additional methods that are used to treat anxiety. So let's begin. Here are some facts about anxiety. Anxiety disorders are most common mental illness in the United States. So about 40 million adults, that's almost like 20% of the entire population in the United States are affected by this disorder. And anxiety disorders are highly treatable, but only about 37% of those people who are suffering from anxiety disorders receive treatment. And people with anxiety disorder are 3 to 5 times more likely to go to doctor and 6 times more likely to be hospitalized for psychiatric disorders compared to those who do not have anxiety disorders. So anxiety disorders has implication not only just having that particular diagnosis, but it could actually contribute to developing a lot of other psychiatric and health conditions that can be negative. And anxiety disorders develop from a complex set of risk factors, just like any other psychiatric conditions, including genetics, brain chemistry, personality, and life events. Pause this video lecture and go to the additional videos to watch, and watch this video to have a glimpse of what it's like to live with anxiety. These are the list of conditions that are included in DSM-5 under anxiety disorders. As you may know, OCD and PTSD are no longer included in anxiety disorder categories because now they have the separate category as obsessive compulsive and related disorders and trauma and stressor related disorders. In this lecture, I'm going to focus on 3 major anxiety disorders, including generalized anxiety disorder, panic disorder, and social anxiety disorder, which is also called social phobia. If you look under resources, there are some measures that are frequently used to diagnose some of these conditions. So take a look. Some of the key symptoms that are found in generalized anxiety disorder is excessive anxiety and worry that lasts at least for 6 months, difficulty controlling their worry, and 3 or more of the symptoms among restlessness, fatigue, difficulty concentrating, irritability, muscle tension, and sleep disturbance. Key symptoms of social anxiety disorder is marked fear or anxiety about one or more social situations, fear of showing anxiety, and the possibility of being negatively evaluated by other people by showing these symptoms of anxiety. And social situations almost always have to provoke a fear or anxiety, and avoidance of social situations with intense fear or anxiety that is out of proportion to the actual threat. And panic disorder is different from panic attack. So just having panic attack doesn't make you diagnosable with panic disorder. So to be diagnosed with panic disorder, you have to have recurrent unexpected panic attacks, at least 4 of the symptoms that you see in this slide, and 1 or more attacks followed by a month of persistent worry. So that's the key kind of symptom from the perspectives of CBT, because that's cognition. So persistent worry about having another panic attack, more panic attack episodes. And because of that, experiencing significant abnormal change in behavior. So let's think about the cognitive model of anxiety. We learned that there are triggering situations that seem to lead to a variety of different reactions at the emotional, behavioral, and physiological level. But we now know that it's not the situations, but it's actually your interpretation of those situations that leads to those reactions. And more specifically to anxiety, there are anxious thoughts mainly that contribute to those reactions. There is a benefit of differentiating different types of triggering situation in treating anxiety, such as environmental triggers, which are external situations that lead to anxiety. And then there are some internal triggers, such as cognitive triggers. These are unwanted intrusive thoughts, images, or impulses. So these internal thoughts themselves actually become triggers, so people get more and more anxious. Another type of internal trigger is interoceptive triggers, which are internal bodily sensations that lead to anxiety. And this is important to acknowledge in treating anxiety, because a lot of times symptoms of anxiety are manifested in a physical and physiological level a lot of times. And sometimes these internal triggers, these physiological triggers, can contribute to really worsening the client's symptoms of anxiety. So some of the common physiological responses to anxiety includes heart pounding, getting sweaty, tight stomach, short of breath, getting really shaky, muscle tension and tightness. All those physiological responses to anxiety can actually become interoceptive triggers, so that sometimes it's actually these physiological responses that begin first, and then when clients notice that these things are happening in their body, they think that there's something's happening to them and they get more anxious. So cognitive conceptualization of anxiety understands these phenomena, these bodily sensations and physiological responses and interoceptive triggers, understand as a response to the perception of threat that's internally going on in the client's mind. Because the clients perceive some threat, whether it's externally or internally, the client's body starts giving quick energy, and sugars and fats start pouring into their bloodstream. And the muscle gets tightened so that they can get into a state of readiness to address that source of threat. They start focusing on danger and really get into that survival mode to address that threat. So the cognitive conceptualization of anxiety disorder is based on the risk and resource model, because people with anxiety has the tendency to always overestimate the level of threat or risk or danger that they encounter. And they, at the same time, underestimate the resources, their ability to cope with the situations. So when there are triggering situations, the clients overestimate danger while underestimating their ability to cope with it. They have increased sense of helplessness and vulnerability, and because of that, clients always resort to behaviors that increase the sense of safety and security, which I'll talk more about later. There are different ways that anxiety gets manifested in cognitive terms. First of all, there is a focus of attention disproportionately on fear situation. In clients having anxiety about having anxiety, cognitive avoidance that precedes behavioral avoidance, because clients first think I shouldn't do this because it's dangerous, which always comes before their behavioral avoidance. And also getting into safety behaviors. I'll talk each of these in more detail. Focus of attention means that clients with anxiety tends to focus disproportionately on the sources of threat, which is also called hypervigilant. And because they're so hypervigilant and really observed into this internal experience of threat, they often dismiss signs of safety that's out there. And because of that, clients lose the accurate or realistic sense of actual danger, which leads to interfering with their daily functioning. Anxiety about anxiety refers to clients with anxiety perceiving anxiety self as a threat. And in that experience, there is some kind of attitude or beliefs that anxiety is bad, it's something to be avoided, or anxiety needs to be controlled. But anxiety can be a part of normal human experience, although normal anxiety should be proportionate to the situation. So people with anxiety gets into this cycle of really focusing on anxiety symptoms, and then where there are a triggering situation, and then they start developing anxiety symptoms, these beliefs and attitudes kicks in, intensifying anxiety symptoms because they get really anxious about having anxiety, and then the cycle continues. So it's important that you engage clients in exploring those intermediate beliefs about anxiety, and then try to evaluate and modify those thoughts to more helpful thoughts, such as anxiety is a natural part of human experience, and anxiety can be accepted and embraced instead of to be avoided. So, I mean, it may be a little uncomfortable to live with anxiety, but you can still manage to achieve your life goals if you learn to manage it. So that's kind of more flexible beliefs and attitudes about anxiety can be helpful. Safety behaviors are actions or inactions that clients take to cope with their interpretation of the triggering situations. So as I explained before, when clients magnify the amount of threat that's presented to them and minimize their ability to cope with that situation, they increasingly become really vulnerable and helpless. And then they start doing actions that helps them to feel safe. So those are called safety behaviors. And some of the example would be, for people who has a fear of developing a panic attack while driving, would do such a thing like having a safety person always in the car, avoiding to driving long distances, or gripping the steering wheel really tightly. For people who have fear of vomiting, carrying around saltine crackers, ginger ale, and other indigestion medication in their purse at all times. Or always like checking where exits are, so that when something happens they can evacuate immediately, or keeping muscle tenses so that they don't faint. There are people who have fear of fainting in front of other people, so that's one of their safety strategies. Going through grocery stores aisles quickly that are further away from an exit. Someone has fear of encountering people, or fear of social situations. Carrying around anti-anxiety medication all times. Checking their purse all the time when their heart rate seems to increase because they are they have fear of having a heart attack. Gripping onto something, looking down, avoiding eye contact in social situations for people who have fear of interacting with other people. Or some of the internal behaviors like counting tiles on the floor, like looking down, worrying and self-criticism, all these things that are happening that could be part of the safety behaviors. So one way for you to help identify these safety behaviors for your clients with anxiety is to just ask this question: did you do anything to try to decrease anxiety? So remember that all these kind of behaviors that may look odd, as you understand their thoughts behind it, they're actually doing these things because they believe getting into these behaviors will actually help them to cope with anxiety or decrease anxiety. What's important for you to know is that different conditions under the anxiety disorder category has a specific cognitive model that's more relevant to the symptoms that are exclusively presented in each condition. So things that I have talked about, the risk and resource model, is more relevant to the generalized anxiety disorder. So social anxiety disorder has a different type of cognitive model, which is called vicious cycle model. So the cognitive model of social anxiety includes anticipatory processing, self-focused attention, and self as social object. Safety behaviors, which are similar to what I talked about in generalized anxiety disorder, and anxiety-induced skill deficits, and post-event processing. Anticipatory processing is intrusive and persistent predictions of poor performance, embarrassment, and rejection that occur in anticipation of a social event, often by people with social anxiety disorder, which are often negatively shaped based on past experiences of failure and negative self-concept. So the cognitive distortion of catastrophization takes place in clients' cognition with social anxiety disorder, but more exclusively around the result of interaction in social situations. So these are different types of anticipatory processing. Predictions about upcoming performance, such as I won't have anything to say at the party, and consequences of the poor performance. For example, thinking that I'll say something stupid, and also predictions about others' reaction. Others will notice how anxious I am. Also predictions about others' disapproval and rejection. Others will think of me poorly. And predictions about manifestation of anxiety symptoms. They often think that the anxiety will be really uncontrollable, so I won't be able to control my anxiety. And also high performance standards, such as I must impress people, I must do this well, things like that. Another important feature in social anxiety disorder is self-focused attention, because people with social anxiety disorder often perceive social situation as an external threat. To avoid facing that threat, they instead focus entirely on themselves, and oftentimes they view themselves as a social object, things that are intensely scrutinized other people. I already talked about safety behaviors, so these are very similar to the ones that I already talked about as part of the generalized anxiety disorder symptoms. And safety behaviors in social anxiety gets manifested specifically more relevant to social situations. So such as like keeping to the edge of the room instead of being at the center, staying in the periphery in the space, holding on to food or drink bottles so that they have something to focus on besides other people. Leaving a message to avoid interacting with a live person, avoiding eye contact so that they don't have to start a conversation with a stranger, constantly preparing rehearsal, like constantly practicing what they're going to say in social situations, and spending a lot of time like writing and rewriting on email, wearing multiple layers to hide sweating in social situation, and talking really quickly to get a conversation or presentation over with really quickly. And because of the tendency to keep avoiding social situations because of fear and anxiety, and their tendency to continuously engage in safety behaviors that makes them like look even awkward and not sociable, people with social anxiety actually lose out the opportunities to develop social skills, particularly if the social anxiety started during the childhood. Throughout the important developmental milestones, kids will miss out opportunities to build a positive social skills. So this is an area that you want to pay attention to, particularly around whether the anxiety is actually more of the perceptions and predictions, how much of that is actually overlap with actual skills deficits, in which case if there is actual skills deficits, your session will include building social skills through psychoeducation and modeling and using problem-solving approaches. And post-event processing is repeated negative appraisal of past performance in social situations and continuously regretting and ruminating about what went wrong. So let's try to conceptualize social anxiety using the CCD diagram that you learned. First of all, I told you that we always start from the bottom part. So we know that typical emotional reactions to triggering situation for people with social anxiety disorder is getting really anxious and also getting fearful. Behaviorally typical be, behavioral reactions is avoidance or safety behaviors. And physiological symptoms are often tightness in the muscle and short of breath and heart racing and other symptoms. And we know that these are all like in response to being exposed to social situations. And then when they are exposed to social situations, they a lot of times that they have this very negative automatic thoughts, such as I'm going to look very anxious, my mouth is going to go dry, I won't be able to think, I won't know what to say, I'll look stupid, I might faint, I'll fail the performance, others will laugh at me, they'll think I'm stupid. And we know that negative automatic thoughts are often tied with a deeper level of beliefs. And people with social anxiety oftentimes have very negative core beliefs about themselves. So oftentimes they think like fundamentally they're incompetent and I'm a failure, I'm inferior, I'm defective. These are very commonly found core beliefs in people with social anxiety. And they, also they have a very negative and maladaptive, unreasonable, intermediate beliefs, rules and attitudes and assumptions. So, for example, I shouldn't show my weakness. Other people are overly critical. Other people are constantly evaluating me negatively. And people are on the lookout for signs of weakness or deficiency all the time. Being criticized and disapproved by others is unbearable. If others evaluate me negatively, that bad impression will be permanent and global. And they also hold very negative assumptions about anxiety itself. So I should not show my signs of anxiety. Anxiety means I am defective. If I monitor my anxiety, then I'll be okay, which is why they constantly get into safety behaviors. So as a result, the compensatory behaviors that they tend to get into is that keep avoiding social situations and continuously monitoring performance and anxiety symptoms. So as you saw, the cognitive model of social anxiety is similar, but slightly different from the cognitive model of generalized anxiety disorder. And similarly, the cognitive model of panic disorder is also similar but different. So basically, when people are exposed to triggering situations, and as you remember, particularly for panic disorder, it's important that you recognize not always external trigger, but sometimes inner sensations. Those internal triggers can be a triggering situation. So when there is a triggering situations, people with panic disorder perceive that as a threat. And then similarly in generalized anxiety disorder, people tend to overestimate the level of danger or threat and underestimate their ability to cope with the threatening situation. And because of that, anxiety is aroused. And when people experience physical and cognitive symptoms of anxiety, what happens is that this is the step that's crucial to understand the difference in the cognitive model of panic disorder, which is misinterpreting this physical and cognitive symptoms, as if this physiological symptoms that they're experiencing is a lot more catastrophic than what they actually are. So people feel like they are actually, going to have a panic attack and, start panicking. So that misinterpretation actually increase their anxiety. And, when there's this vicious cycle, people tend to have panic disorder. So this is an example of cognitive model of panic disorder. Let's say a person is working in the office and sees boss coming out of the office, and he has lots of automatic thoughts. Oh, maybe he's going to confront me about my missed work or my being late, whatever. So this person is going to interpret the boss coming out of the office as a threat, and then start experiencing anxiety symptoms, some cognitive symptoms, is as well as physiological symptoms like pressure in chest, breathing fast, getting hot and sweaty, and muscle tension, lightheaded, and heart racing. And this person interpret all these physiological symptoms as a sign of him losing control. So he starts having these thoughts, oh, I'm going to lose control, I'm going to pass out, and then that really increase the anxiety on spot, which actually leads to this person having panic attacks. So when this thing continues, there is like increased fear and embarrassment of the possibility of having another attack. So that actually makes a person develop symptoms of panic disorder. So far I introduced diagnostic criteria for different conditions within the category of anxiety disorder. I also talked about different cognitive models of each different condition within the category. And because there are some shared characteristics of any anxiety related disorder, there are some commonly used method of treatment, but in terms of the cognitions that you want to target through CBT, because the cognitive model of each different condition is slightly different, you will want to target different types of cognitions in the cognitive intervention. So I'll talk more about that now. So in terms of medications to treat anxiety disorder, antidepressants are used such as SSRI and SNRIs, in buspirone, and in some limited occasions, benzodiazepines are used to treat anxiety disorder. Cognitive behavioral therapy is one of the most frequently used psychotherapy to treat anxiety disorder. And there are two major approaches that are frequently used in CBT to treat anxiety. The first one is exposure therapy. The other one is cognitive therapy, using many of the cognitive interventions that you have learned so far, but also guided by the cognitive model for each specific disorder within the anxiety disorder category. Exposure is one of the most commonly used technique to treat anxiety, and the theoretical basis of exposure comes from the emotional processing theory that was developed in 1980s by Fo and Kozak. And the central concept in emotional processing theory is fear structure, which is a mental frame in a person's mind that contains some information about fear stimulus and a fear response. and the meaning of this fear stimulus and response. So what that means is that let's say that you had a car crash. So anything that reminds you of that car crash, that traumatic event, are fear stimulus. So it could be a car or a highway or a person who was sitting next to you when you had the accident, or it could be a color of the car that hit your car. So, if it happened to be a green car, somehow that had a big impression on you, you could even associate color green as your fear stimulus. And all these trauma reminders are associated with your fear response, whatever physiological, behavioral, emotional responses that you had in that traumatic incident. And you start attributing some meaning, such as like car equals danger, or driving can be dangerous. So that becomes your fear structure. And the problem with the fear structure is that because it's uncomfortable, because those fear stimulus reminds you of all the uncomfortable fear responses that you had, people develop tendency to avoid or escape any situation that reminds them of that traumatic incident. And because of that, this person doesn't have an opportunity to learn new information about feared situation or fear stimulus. So this mental structure, this fear structure, gets solidified over and over. What exposure does is that by exposing a person to a feared situation, or comes near to fear stimulus, the person has a chance to incorporate new information into their mental structure. So let's say that after you had that car crash, you're starting to drive again, and you had no crash for 5 days, and then 10 days, and a year went by without having any accident. And then your association between this fear stimulus and fear response gets weakened, because all this new information about car driving but no accident, that information can be incorporated into your memory, into your mental structure. So exposure breaks this relationship, this association between fear stimulus and fear response, and then a person can develop new meaning about this fear stimulus and fear response. And that's why people with trauma, anxiety disorders can be treated using exposure. There are multiple types of exposure you can facilitate for clients with anxiety disorder. First type of exposure is imagery, which you're already familiar with. So in CBT treatment for anxiety, you will engage clients in imagery to reenact clients' feared situations, to elicit and identify their negative automatic thoughts, and going through the process of identifying more balanced, realistic, and adaptive perspectives, and then prepare them to better cope with those negative automatic thoughts outside a session through this practice that you do in session. In vivo exposure is where you collaborate with the client to create a hierarchy of anxiety-provoking situations. And then you expose clients to these feared situations step by step, starting from the least feared situations to most feared situations, until they can do the most feared, most anxiety-provoking situations. So this technique is frequently used in trauma treatment. So you will learn more about this in the class where we focus on CBT for trauma. So interoceptive exposure is frequently used to treat panic disorder. You learn that based on the cognitive model of panic disorder, one of the central mechanisms that maintain panic disorder is misinterpretation of physical symptoms of anxiety. So interoceptive exposure intentionally creates situations that will trigger physical reactions that are very similar to the symptoms of anxiety, and gradually, repeatedly, by repeatedly exposing your clients to do this physical reactions, you gradually help your clients to understand that these physical reactions can happen and they're not really as dangerous and catastrophic as they believe. So the exercise that you do to induce physiological or physical reactions that are similar to symptoms of anxiety is called induction exercise. So these are some of the examples of induction exercise that are frequently done in interoceptive exposure. So for example, you have your client hyperventilate for 1 minute, or hold breath for 30 seconds, breathe through narrow straw for 2 minutes. All these exercise can help induce this physical sensation of breathlessness or smothering sensations. And spinning around using the spinning chair at medium pace while standing or sitting the spinning chair for 1 minute, or place head between knees for 30 seconds and then raise head quickly, and shake head rapidly from side to side for 30 seconds. So these kind of exercise can induce physical sensations of dizziness and feeling like fainting. So these are just only like a couple of exercise examples, but there are a ton of other physical exercise that are done in interoceptive exposure, and this induction exercise is known to be quite effective in treating panic disorder. In addition to exposure, you will use a lot of cognitive interventions that you've learned so far in class. First, by identifying distorted and unhelpful thoughts, including automatic thoughts, intermediate or core beliefs, and evaluating those thoughts by looking at the validity and utility of those thoughts, by engaging clients to look at evidence for and against those thoughts, and also advantages and disadvantages of holding those beliefs, and then modifying those thoughts. Because, as I mentioned, the cognitive conceptualization of anxiety disorder is based on risk and resource model. Clients have the tendency to always overestimate the level of threat while underestimating their ability to cope. Because of that, your strategies to modify clients' distorted and unhelpful thoughts would involve decatastrophization, so that clients can reduce a level of the perception of the level of threat, and also problem solving, so that clients can increase the perception of their capability to handle situations when the fear situation actually happened. As you learn kind of generic questions that you will ask to identify automatic thoughts, it's what was going through your mind, And knowing that negative automatic thoughts related to anxiety often involve prediction, you can vary the questions that you ask by asking, what were you predicting? What were you expecting? What were you afraid that could happen? What did you anticipate? What were you imagining? So all these different variations of questions could actually help the client to identify the worst case scenarios that they were predicting. When evaluating and modifying negative cognitions to treat anxiety, there are specific cognitions that you would look at for each different subtype of anxiety disorder. For example, for generalized anxiety disorder, because that particular disorder is characterized by persistent and excessive worry about a number of different things in life, it will be important for you to look at some persistent thought patterns that leads to anxiety. For example, by identifying cognitive distortions that your clients tend to get into a lot. Also, challenging thoughts that overestimate risk. That's kind of applicable to any other types of anxiety disorders. And also identifying and changing catastrophic thinking, which is also applicable to other types of anxiety disorders. For people with social anxiety disorders, you will focus on helping your clients to change their negative self-perceptions, particularly related to their limited social skills, and also changing their thoughts about overestimating negative consequences of making a small mistake or being embarrassed in public, which happens to be the greatest fear for these group of people, and also educating clients about the possibility of changing emotional responses by changing thoughts. For people with phobia, because these people tend to have a very unrealistic expectation about what's going to happen if they do something, if they engage in a feared situation. Your work would focus on replacing those unrealistic expectations with more accurate predictions and interpretations. For people with panic disorder, because these people have the tendency to always overestimate the risk of having physiological responses, your work will focusing on providing opportunities for clients to learn about physical sensations are not necessarily always harmful, and also teaching clients to reappraise the meaning of the physiological symptoms instead of catastrophizing. That concludes today's lecture. You have your final video reflection assignment that's due next week. You will see Dr. Fidesky working with a client with panic disorder. She'll demonstrate some cognitive interventions as well as interceptive exposure technique. So watch that video and list all the CBT skills that you saw that she was using in this session. So that's it. Have a great week, and then I'll see you next week. Thanks for watching. Bye.